it's a very huge topic of heart failure, its prevention and management. But I would try to summarize the things for you and make it easy for understanding. So as AHA defines heart failure, it is a complex clinical syndrome with symptoms and signs that results from any structural or functional impairment of ventricular filling or ejection of blood. So please remember, it's not only the systolic failure, but it's also abnormality of left ventricular filling. You all have studied this pathophysiology of heart failure, but for understanding of the mechanism of action of various drugs, you need to know a little bit of pathophysiology. So any structural abnormalities in the heart, whether it is a pericardium, myocardium, or valvular lesions, that would ultimately lead to the heart failure. And whenever there is heart failure, what happens? There is in-organ hypoperfusion, and there is increased pulmonary capillary wedge pressure. So all the signs and symptoms of heart failure are because of this increased pulmonary capillary wedge pressure. And a lot of compensatory mechanisms come into play while there is heart failure. And all the adverse effects of cardiac failure is because of these compensatory mechanisms. And this has made the foundation of various drugs which acts on the different pathways of these compensatory mechanisms. As you know, there is left ventricular dilatation, there is activation of sympathetic nervous system, and then there is activation of renin-angiotensin system. So as a result of that, there is one overload, there is increased myocardial demands, and there is systolic dysfunction. Why heart failure is important? Actually, if we compare the mortality associated with the heart failure, it is almost or even greater than some of the malignancies in males and females, like ovarian tumors, bladder cancer. You see, heart failure has a very worse prognosis. We need a proper infrastructure, as if you visit cardiology ward right now, you will see a lot of patients with heart failure. And we need more beds. So heart failure, there is increased hospitalization. And the problem is not only admission and stabilizing the patients, but once the patient is stabilized, there is again readmission. So even in US, the 30-day readmission rates exceed 25% with so much advancements in cardiology. So because it's not only ischemia that is responsible, but there are a lot of other causes which causes heart failure. So once we receive a patient, we try to stabilize. I will be discussing in a minute. And after stabilization, what happens? There is a cascade of events again, because there are lots of deficiencies. It's not only we should offer the treatment in the hospital, but the actual problem starts after we discharge the patient, because our counseling and complying to medication, and there are so many other problems associated with the affordability and these issues. So these patients usually forget their drugs, and then they are again come with the heart failure and decompensated state, and again readmissions. So there is a huge burden on our units. If you see all the cardiology units all over the KPK, so the number of admissions because of heart failure would be more than any other disease. So for the proper understanding, we have the AHA divides heart failure into 4 stages. Stage A is actually, there are only risk factors, but no structural heart disease. And it is at this stage that we can prevent the progression of heart failure from stage A to stage B. Stage B is actually, there is no heart failure, but there is only structural heart disease in the form of myocardial infarction, in the form of cardiomyopathies. But remember, there are no signs and symptoms of heart failure in stage B. After the progression to stage C, we do get the symptoms and signs involved in the actual heart failure. And when the stage C progresses, it becomes stage D, where it becomes very difficult to control the things, to control the symptoms. As far as classification on the basis of left ventricular ejection fraction, the AHA has divided it into left ventricular ejection fraction. If it is less than 40%, that is heart failure with the reduced ejection fraction. There is another term, improved heart failure with the improved ejection fraction. These are those patients in which initially the ejection fraction was less than 40%, but after treatment there is improvement in the ejection fraction and it improves from 40%. So this is called heart failure with improved ejection fraction. Then there is a term which is heart failure with the mildly reduced ejection fraction. So what does it mean? It means the ejection fraction is less than 50%, but it is in between the range of 40 and 50. And when it becomes more than 50%, it means the ejection fraction is normal, but it is with the heart failure with the preserved ejection fraction. So this is a basic algorithm for understanding. When we receive a patient, we take a detailed clinical history, we examine, and we do some baseline investigations like electrocardiography, chest X-ray, and then there are some baseline investigations which are class 1 recommendation that you must be doing all the baseline investigation, including thyroid function tests. And then for the diagnostic and prognostic purposes, we do the N-terminal pro-BNP, and if the patient is already diagnosed case, there is no extra benefit other than the prognostic value of BNP or pro-BNP. Transparency echo is done and it is almost diagnostic on the basis of ejection fraction. But in some patients, we do need some detailed studies. So echocardiography may not be 100% diagnostic, and sometimes we don't get proper window. So we do cardiac MR and CT scan for more structural detailed studies of these patients. So once the diagnosis is confirmed, we again divide, as I said, on the basis of ejection fraction, and we start the treatment and treat the precipitating factors and the underlying etiology. As you all know, other than ischemia, these are the different causes of heart failure. So coming to a recommendation, again, as I said, BNP and N-terminal pro-BNP have diagnostic and prognostic values. In some cases, we are discussing the prevention. So there are patients in whom we don't know the etiology, and in young cardiomyopathies, this should be the practice that the genetic studies and genetic counseling should be done in cases in which we get some young cardiomyopathies without any ischemia and any other cause. This is just the landmark trials to show you that these trials were basically done on different group of drugs which have been shown to improve the mortality regarding the beta blockers, ACE inhibitors, statins, and the sacubitril valsartan. We will be briefly discussing stage A, as the emphasis is more on the prevention. So it is at this stage that we offer primary prevention. So proper guideline-directed treatment of hypertension, diabetes, and other cardiovascular risks have to be well controlled to prevent the progression of stage A to stage B. It also includes healthy lifestyles, physical activity, maintaining a normal body weight, healthy diet, and avoiding the smoking and reducing the stress. Some risk factors which are responsible, and these need to be addressed to prevent the progression of stage A to stage B. So for hypertension, you need to know what's the normal blood pressure. So as AHA defines in 2002 guidelines, the blood pressure of 120 by 80 is not a normal. You have to have a blood pressure of less than 120 by 80. Previously, the range was 130 to 139 was pre-hypertension, but now it has been included in stage A. So in our population, it's a very common that blood pressure is not frequently checked, and when you see a patient and accidentally check the blood pressure is high. So you need to know these values for the proper control of risk factors and prevention of cardiovascular risk and development of heart failure. We do calculate 10-year risk of atherosclerosis cardiovascular disease by using different calculators and available on mobile apps as well. You just put these variables and you get your 10-year atherosclerotic cardiovascular risk. On the basis of this, if your risk is 5 to 10, it is low. If it is 10 to 20, you are in intermediate risk. If it is more than 20, you have a high risk. So there should be a proper counseling regarding some risk enhancing factors. Like there may be a family history for that. The males, the family history, if someone in the family died and he is a male and age is less than 55 years, so we call it a positive family history. And if in female, if it is less than 65 years, death due to cardiac causes, this is significant family history. Similarly, there are so many other conditions. I don't want to go into the detail as my next speakers will be talking about these regarding prevention. But as far as it is associated with the stage A, so I have to give a brief touch. Chronic kidney diseases, there are inflammatory conditions, then there are high risk, then some other risk factors like apolipoprotein, and so in whom we do offer coronary calcium scoring. There may be some risk factors, and if your age is between 45 to 75 years, what would you do? And the patient is asymptomatic and he is just worried that I have a positive family history, so please doctor do something. So you must be knowing that in such patients we do offer calcium scoring, and by just doing the CT scan, cardiac CT, we can calculate the CT scan. If your risk is low and there are no family history, no risk enhancement factors, no need to worry. If the risk lies between intermediate, so 10 to 20%, you need to do calcium scoring. And if you are already in high risk or you are symptomatic, so there is no need of doing calcium scoring, you just start treatment. So this is how on the list of calcium scoring, if your score is 0 to 100, you are in the low risk. And if there are no risk enhancing factors, you don't need to take anything but just lifestyle changes. If the score is more than 300, you need to worry and you start the patient on statins, high intensity statins. As you all know, healthy lifestyles, healthy diet, what does it mean by healthy diet? More fruits, vegetables, less saturated fats, exercise, and then there's weight reduction, smoke cessation, and stress management, of course, very difficult in nowadays. So coming to stage B, in which we basically do have patients with structural heart disease, like patient, for example, having myocardial infarction with the low ejection pressure. But it doesn't mean for my junior colleagues, you don't call it heart failure, because patients having a structural heart disease with low ejection fraction, so you need to start the patient on ACE inhibitors, beta blockers, statins. And there is class 1 recommendation for patients who are post-myocardial infarction and more than 40 days, and ejection fraction is less than 30%, even if NYHA class 1, so you have to have ICD, and this is class 1 recommendation. We should have a proper program of dealing all the structural and cardiovascular disease. Like you should have a program for STEMI, as we have started primary PCI. So mashallah, our heart failure patients are now becoming on decline. So in the same way, you need to treat the congenital heart disease, valvular heart diseases according to their guidelines. This is just the summary which I have for. Coming to stage C, so there are basically pillars of management. Stage C is actually we are dealing now with the heart failure. So RAS, renal angiotensin inhibitors, there is ARNI, another group of drugs, beta blockers, MRA, SGL2 inhibitors, and loop diuretics. Sodium restriction is the first thing which you would offer for the patients with heart failure. Similarly, if you receive a patient with a volume overload condition, so you would of course start on diuretics. If the patient is not responding to a diuretic on the maximum doses, you need to start on potent diuretic like metronidazole. So what I would bit more time on ARNI. ARNI is actually angiotensin renal neprilysin inhibitors, and this is a new group of drugs which have been recommended now as class 1 in the treatment of heart failure. And you should be knowing what are the contraindications and what precautions you should take. You should not be giving it with ACE inhibitors or within 56 hours of the last dose of ACE inhibitors. So it has actually combination of sacubitril valsartan. So there are two action complementary effects of both the drugs, in which we get vasodilatation and increased diuresis. So PARADIGM heart failure was the randomized control trial which was done on the efficacy of this ARNI. And it was shown that the N-terminal proBNP was significantly reduced and consistently reduced by this ARNI group of drugs, and which reduced the wall stress on the myocardium, more diuresis and symptomatic improvement and quality of life. Similarly, pioneer heart failure was another randomized trial which was done on the decompensated heart failure. Once they were stabilized, then the patient was studied and their clinical effects were studied, and death, hospitalization, and need for left ventricular assist device or cardiac transplant was significantly reduced. Again, stage C beta blockers, bisoprolol, carvedilol, sustained release metoprolol succinate is recommended. MRA, another group of drugs which are recommended in patients having normal GFR and no renal pathology. What do they do? SGL2 basically inhibit the reabsorption of glucose, and there is more osmotic diuresis and relief of symptoms and prognostic important. So these were the major trials which were done on SGL2. DAPA heart failure, Emperor preserved and Emperor reduced, and the findings were reduction in the cardiovascular deaths or first hospitalization for heart failure and all-cause mortality. This is the stepwise management of stage C and D. So what would you do? You will start on all these drugs, then you will measure the ejection fraction. If it is less than 40%, you will again assess NYHA functional class, and if the patient is not improving, you will definitely offer ICD and CRTD, and if even then the patient is not improving and there is a refractory heart failure, so there is progression, so you need to refer for the heart failure in stage D, having the facility for dealing such patients. Regarding ivabradine, so it is only and only recommended when patient is a maximum beta blocker dosage and the heart rate is still not controlled, so you need to add another drug, and provided the patient is in sinus rhythm. Another drug which has been now recently studied in some few trials, Veripoget, and this is a polyotropic agent, and it has shown to reduce hospitalization and cardiovascular mortality. Regarding the ICDs, again, as I said, if the patient is symptomatic and having ejection fraction less, so you have to have ICD. And for CRT, the patient should be having LBD morphology, ejection fraction less than 35% within sinus rhythm and NYHA class 3 and 4 symptoms. Regarding Valvular pathology, you need to have the units for dealing with structural heart disease, we are doing PTLCs, and similarly, valvular replacement should be done earlier. So there is a term which is called secondary mitral regurgitation, which is associated with the dilated heart, and how you deal that. You start the patient on guideline-directed medical treatment, and if the ejection fraction is less than 50%, there is a term which is transcatheter H2H mitral valve repair. The patient, you may refer for if there is need for CABG, so you need at time you need mitral valve repair surgery. Mildly reduced ejection fraction you treat in the same way. Similarly, if there is improved ejection fraction, please remember that don't stop the medication at once. Patient at time with Kiri-Patin cardiomyopathy comes to you with the improved ejection fraction, but it doesn't mean that you will stop the treatment. You will still continue it. At one stage, we need to have advanced centers for that, for proper referral and management, for left ventricular assist device, mechanical circulatory supports, and cardiac transplantation. At times, the patient may not be a candidate, so the patients may just need inotropic support and continuous treatment regarding having units and beds availability for dealing with such sort of patients. There are maybe some associated pathologies with the heart failure, like atrial fibrillation is very common, and you should be knowing that when to start the patient on anticoagulant. For that, you need to know the chest for. And at times there may be need for atrial fibrillation ablation. So the conclusion of my talk is heart failure is a common and deadly syndrome. It has mortality more than most of the common cancers. Now, effective evidence-based treatment is available to reduce mortality, hospitalization, and improve quality of life. The pillars of heart failure: ACE inhibitors, ARBs, ARNI, beta blockers, ioglidine, MRA, SGLT inhibitors. The general policy is to start low, go slow, but try to achieve guideline recommended maximum tolerated dose. Close monitoring and timely referral to experts is crucial. Always consider advice for device treatment in selected patients. So there is a case scenario for you, and if someone have a quick response, so he may be given a prize by the management. So this is a 76-year